The U.S. healthcare system spends about $31 billion on treating substance use. Separate from what we spend on treating substance use, it costs about $600,000 for the lifetime cost of treating HIV. It costs somewhere between $50,000 and $75,000 these days to cure a case of hepatitis C. The economics of treating substance users is complex because they are treated both in the healthcare system and in the behavioral health system, which includes substance use and mental health treatment. Now, as a result of healthcare reform, the systems are coming together. CHERISH is a national center of excellence funded by the National Institute on Drug Abuse to promote health economic research related to substance use and the treatment of HIV and hepatitis C in substance users, particularly in the context of the changes in the healthcare system in the United States. We are a very unique center because we have been able to draw on national experts at many institutions, at Weill Cornell, at Boston Medical Center, at the University of Pennsylvania, and at the University of Miami.
We come from a variety of disciplines. We are disparate in terms of location, but we're intimately connected in terms of the work that we're doing.
Our services that we offer include some work helping people think about large data sets that have health economic information contained within them that people may want to use to conduct a research study that they've been thinking about but perhaps aren't exactly sure what would be the right data set with which to work. We also offer a service in simulation modeling, so we can help folks that are interested in doing cost-effectiveness work or sort of long-term health outcomes projections using simulation models of HIV and hepatitis C virus.
We run a methodology consultation service that helps researchers to develop grant applications, and we also are doing our own research on improving methods to describe health economic outcomes.
CHERISH provides pilot grants to people who are new to the field, so either early investigators or senior investigators who are switching their focus of study to sort of bring them into the field, and then training to provide training for economic evaluation to people who haven't done that sort of evaluation in the past.
In our pilot grant, our focus is on a very prominent policy to combat the opioid epidemic. The policy is the state prescription drug monitoring programs, and asks the question, how does the implementation of that database make a difference in terms of prescribing of opioids and other controlled substances to patients?
It's been really good for me as a clinician in training and a physician scientist in training to spend my day-to-day seeing patients that are infected with HIV, hepatitis C, that are struggling to interface with the healthcare system in a lot of ways. I found it really helpful to be able to understand that not just from an individual patient interaction perspective, but also understand how to look at that and study it from a health systems perspective. And being able to do those two things at the same time in the same program, I think has been enormously complementary.
LDI, or the Leonard Davis Institute, is the hub for the policy and dissemination core of CHERISH. We disseminate and communicate the research that happens at CHERISH and with CHERISH affiliates. The focus is on the end users for this type of research and identifying what the needs are of those stakeholders and feeding it back to researchers so that the research that happens at CHERISH is responsive to the needs of these primary stakeholders.
We at CHERISH recognize that substance use and the medical complications of substance use need to be viewed through the lens of medical care. And the value of substance use treatment needs to be viewed in the same way that we view the value of other medical treatments.
I hope that CHERISH makes it possible for people who might not be career-long healthcare economists to realize that they have data that are important, that they could do a health economic evaluation alongside those data or leverage those data in a health economic way that would really expand their entire portfolio of work, really add to the sort of significance of their findings and increase their generalizability at a policy level.
We've had a very exciting startup year and a half here at CHERISH, and we're looking forward to engaging more nationally by attending national meetings, such as AASLD, and by engaging more with clinical researchers, health services researchers, policy makers, and the advocacy community.